Hi everyone, thank you so much for watching. Welcome to researchmd.com, and we're going to go over a topic, very important ECG or EKG topic on left bundle branch block today. Again, my name is Dr. Pramil Cheriyath, and I work as a program director, internal medicine, transitional residency, also director of research, and then I also hold an assistant professorship at Hackensack School of Medicine. Okay, so our topic today is going to go over the left bundle branch block. Okay, now just look at, anytime you start a topic, we need to kind of touch the epidemiology a little bit. So let's look at the epidemiology of left bundle branch block. The prevalence of left bundle branch block is less than 1% of the population. It increases with the age. Prevalence by age 75 is around 2.3%. When you hit by it, when the age become 80, it can go up, the prevalence can go up to 5.7%. In some studies it has gone like 7% and 8% also. Please make a note of that. In the general population, now let's look at the incidence of left bundle branch block was 3.2 per 10,000 and for men, and 3.7 per 10,000 for women. So slightly increased in the female. Okay. So the next step, we're going to look at the normal conduction pathway. We got the SA node, the signal and then going to AV node, his bundle. Then we have right bundle branch block and the right bundle branch and the left bundle branch. And the left bundle branch have like two other pathways, which is one is left anterior fascicle and the left posterior fascicle, and then the whole ventricle get depolarized. Okay. Now let's look at the pathophysiology. We're going to look at like what are the main causes. Left bundle branch block, number one, you have structural heart disease, and so it's very important to get an echocardiogram. Hypertrophy, dilatation, fibrosis of the left ventricle, ischemic heart disease, cardiomyopathy, advanced heart disease, and aortic stenosis. Now, it can also cause by toxic substances and toxic situation like hyperkalemia and digitalis toxicity. So, when you look at the primary degenerative changes, you got Lenegre disease, which is actually degenerative disease of the conduction system. And when you come to the left disease, you got the sclerosis and calcification of the cardiac skeleton. Okay. Now let's move on. Let's look at the pathophysiology of the conduction and kind of link to the EKG changes. We have first at the left bundle branch block, normal septum depolarization is reversed, traveling right to left, and then that can cause absent Q wave in lead 1, V5, and V6. And the right ventricle depolarization normally, the left ventricle depolarizes last, and the left ventricle depolarizes more slowly than the normal. Aortic valve closes later than normal during each cardiac cycle. That make the QRS complex greater than 120 milliseconds. Okay, very, very important finding. And then sequential activation of the ventricles from right to left, that can cause like T wave opposite in the polarity of the QRS complex. You got dominant RS wave in V1 and V2, broad notched slurred R wave in lead 1, AVL, V5, and V6, and the R peak time is greater than 60 in V5 and V6. Another important finding. So we're going next we're going to look at an EKG. First let's look at the EKG criteria for the definition or diagnosis of the left bundle branch block. Okay. So we're going to summarize. Number one, we talk about the QRS duration has to be greater than 120 milliseconds. Okay. Number two, broad notched slurred R wave in lead 1, AVL, V5, V6, and an occasional RS pattern can be seen in V5, V6 attributed to displaced transition of the QRS complex. Third criteria, absent Q wave in lead 1, V5, V6, but in lead AVL or narrow Q wave may be present in the absence of myocardial pathology. And number four, you have the right peak time greater than 60 milliseconds in V5, V6, but normal in lead V1, V2, V3 when small initial R wave can be discerned in the above leads. Now let's look at the EKG. Again, we said number one finding greater than 120 millisecond, which everybody knows that, like three small boxes. And the next thing in this EKG, we're going to look at the notched R wave in lead 1. See that? You can see it over here. And then what do you have? Something called R peak time greater than 60 millisecond in V5 and V6. Okay, so just if you look at it in the V5 and V6, R peak time is greater than 60 millisecond. So what is R wave? R wave peak time is known. It's also another term for it, intrascoid deflection. Is the time from onset of earliest Q wave or R wave to the peak of the R wave in the lateral lead, say VL, V5, V6. So we put a picture right there so you can see what is R peak time. Now, let's look at some statistics. Asymptomatic left bundle branch block. Okay, if you see in a left bundle branch block in an asymptomatic patient, like a younger patient, probably the prognosis is pretty good. Usually, they come into the office, somebody do an EKG and they found it, patient is not symptomatic, and if they're younger and if they don't have any other structural disease, the prognosis is very good. We get older and if you diagnose even asymptomatic left bundle branch block in the older people could be like a problem. So that can put the patient in increased mortality risk, and the prognosis is also is good if there is no structural heart disease. Okay, so age is very important. If an young patient asymptomatic, the prognosis is good, but if it is older, even if it is asymptomatic, you just have to be very careful. Studies have shown like within 10-15 years they could go into CHF or myocardial infarction and die. So we're going to look at two landmark studies looking at the left bundle branch block patient. In this women's health study, like one of the best studies in the United States, look at the women's health condition. They looked at around 714 women with a left bundle branch block with a 14-year follow-up. It's a prospective study. And if you look at the hazard ratio for CHD death were 2.92, and the confidence interval between 2.08 and 4.08. And the all-cause death hazard ratio is also high, is 1.43, with the confidence interval 1.11 to 1.83. In CVD-free women, significant predictor for CHD death, fully adjusted for hazard ratio was 2.17. So in this study, the prognosis is not very good, right? They have extremely high risk of CHD and the all-cause mortality also. Remember that. Now, another study they looked at, the famous Framingham study was done in Framingham, Massachusetts. In this study, there was around total number of patients they followed was 5,208 patients, and follow-up period was 18 years. And in this group, 55 people developed left bundle branch block. Mean age at onset was around 68 years when they developed left bundle branch block. Okay, largely in people with hypertension, cardiac enlargement, coronary artery disease. We already talked about the link between structural heart disease. And 48% developed coronary artery disease or CHF. 50% died from cardiovascular disease. Increased risk for men. Only 11, this is very important, in Framingham study, only 11% remained free of clinically apparent cardiac disease. That means around 89% have developed some kind of cardiac complication, and 50% of the people died from cardiovascular disease. Very important finding. So we have to take left bundle branch block very seriously. Okay, now, Sgarbossa Criteria is also, you may hear about it. This is the criteria, it's an excellent tool. When people are suspecting a left bundle branch block and the myocardial infarction, we use this criteria. Now let's go back and look at what Sgarbossa Criteria. There's around 3 criteria. And you can have ST segment elevation 1 mm or more concordant with the QRS complex, which is a positive complex in any lead, you get automatic score 5. Okay. In number 2, ST segment depression 1 mm more, 1 millimeter or more in lead V1, V2 or V3, you get a score of 3. And number 3, ST segment elevation of 5 mm or more, discordance with the QRS complex. Okay, discordant with the QRS complex in any lead, you get a score of 2. So a Sgarbossa score is greater than 3, has a high specificity, 98%, and sensitivity is a little bit lower in that criteria. Okay. Now, this is the Sgarbossa Criteria. We talked about ST segment elevation, talk about ST segment depression, and all of that is in this slide. Okay, so you look at the point. If the point is greater than 3 points, we have to, specificity is extremely high. Now, what happened when a patient, this is a very important slide. A patient come in with a chest pain into the emergency room and did an EKG, and it's a new or presumed left bundle branch block. When I say presumed, you did an EKG and you go back and see, first thing always when you see an EKG, I do is like look back and what's the previous EKG looks like, right? If you cannot find it, nobody did an EKG, presume it's a new onset left bundle branch block, okay? Again, if there is a new or presumed left bundle branch block in a patient with a chest pain, assume as ST segment elevation MI, and you have to call cardiology right away, and they may have to go for like a cardiac cath. And this is again is the 2021 AHA ACC guidelines. Okay, thank you so much for watching this presentation. We will be back with more presentation. Please support our channel by subscribing. Please click the subscribe button below. Thank you again.